You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you to the March 2026 edition of Editor's Summary/Highlights. In this month's in-depth interview of one of our highlighted papers, Dr. Jeffrey Dribbin, our osteoarthritis editor, is speaking to Drs. Jocelyn Waghorn, Selena Maxwell, and Miles O'Brien on behalf of all of the co-authors regarding their paper, Association of Frailty with Risk of Osteoarthritis Development, Progression, and Worse Outcomes in Older Adults.
Given the different variables that you've had as outcomes, I was wondering if you could highlight from your perspective the most significant findings that you'd like our readers and listeners to be aware of.
Yep, I'll jump in for that one. So yeah, as we said, we really wanted to represent and look at osteoarthritis across the whole disease course. And so just a little introduction to the data we used might be helpful. So we used the Osteoarthritis Initiative dataset, which is a multi-center US-based study funded by both like the NIH and other pharmacy partners. And it's an observational longitudinal study that aimed to look at osteoarthritis incidence and progression. And it's a really, really rich data set that has clinical symptoms, imaging, and again, they're followed for about 9 years. And so we had this really big wealth of data in order to address this question. So we wanted to kind of find all of the different outcomes that we could out of in this data set when it came to kind of clinical features of osteoarthritis. And so we looked at incidence and then the progression as measured by the knee osteoarthritis outcome score subscores, falls as like a consequence of the symptoms of osteoarthritis and again, the end stage knee and joint replacement surgery. And just to summarize our kind of main findings is that frailty score influenced both incidence, all of the outcome scores for the KOOS, as well as increased risk of falls. But it didn't seem to really have much of an effect on time to event for knee and hip joint replacement surgery. So we kind of like the biggest takeaway I would say is the incidence and the symptom progression. And so we looked at incidence with multivariate logistic regression model and a 0.1 change in frailty, which just to kind of contextualize, a 0.1 change in frailty is like a transitional state from mild frail or to moderately frail or moderately frail to severely frail. So that's why we use that kind of cut point. Actually increase the risk of developing osteoarthritis by 65 to 73% from 3 to 9 years. And so that's a pretty big impact. And then looking at knee osteoarthritis outcome scores, again, there's 4 subscores: pain, other symptoms, function and recreational activities, as well as quality of life. And the KOOS, it's usually considered like 8 or more point change is clinically significant. And for both quality of life and for function, the frailty index score change of again 0.1 would impact those measures by it was 8 or 9 points. So like a reduction in KOOS of 8 or 9 points. So that would be clinically significant. And so it's really important to consider frailty kind of across the course of osteoarthritis, and including considering it as a risk factor.
I hope you enjoyed listening to part of Dr. Dribbin's interview with 3 of the authors of a paper titled Association of Frailty with the Risk of Osteoarthritis Development, Progression, and Worse Clinical Outcomes in Older Adults. I hope you will listen to the complete interview, which is available at either our YouTube channel or at www.jroom.org. Now moving on to the other highlighted articles of the March edition of the Journal of Rheumatology. A little note here, I'm continuing to try to explore the best format for the podcast for you, our listeners. This month, the podcast will be a hybrid of two previous formats. I will review in detail my highlighted articles, which I've chosen at editor's picks, and then I will summarize briefly the other articles. The first article you have already heard about, and I encourage you to hear the complete interview. The second article highlight is titled The Risk of Osteoarthritis in Patients with Inflammatory Bowel Disease Receiving Treatment with Biologic or Janus Kinase Inhibitors, and is by Kim and co-authors from the University of Ulsan School of Medicine, Seoul, Republic of Korea. In this retrospective cohort study of 1,553 patients with IBD from a single center who were treated with either a biologic or a JAK inhibitor, 106 or 6.8% of the patients developed musculoskeletal symptoms during the aforementioned treatment. Of these 106 patients, 30 were diagnosed with spondyloarthritis, 20 axial, and 10 peripheral. This occurred after a median follow-up of 5.2 years. This represents 28% of the cohort who developed MSK symptoms, or another way of putting it is 1.9% of the total cohort. The majority of patients with IBD had Crohn's disease. When the authors compared the 30 patients who had MSK symptoms and who then went on to diagnosed with spondyloarthritis to the 76 patients who had MSK symptoms but were not subsequently diagnosed with spondyloarthritis, the authors found that a higher ESR at initiation, a higher percentage of patients had HLA-B27 antigen in the patients who progressed than those who did not progress. The authors did not find any significant association with the type of biologic used or the JAK kinase inhibitor and the development of spondyloarthritis. There was, however, an association with a higher Crohn's disease activity in the development of spondyloarthritis at the time of initiation of biologic or JAK kinase inhibitor. In the accompanying editorial titled Evaluation of Emergent Musculoskeletal Symptoms in Patients with Inflammatory Bowel Disease, How Does Imaging Help?, Dr. Walter Maksinovich from the University of Alberta, Edmonton, Canada, reviews the literature on the association of peripheral and axial spondyloarthritis and IBD. He then reviews the above-named paper and puts it into context of the world literature to date. An important feature of this editorial is the comments on the role of MRI in the evaluation of patients with IBD and MSK symptoms. Cardiovascular disease remains an important cause of morbidity and mortality in patients with inflammatory arthritis. The next highlighted paper, Geiger and co-authors from Medical College of Wisconsin, Milwaukee, USA, and Boston University, Cobain-Vesedian School of Medicine, Boston, USA, examine this issue in their paper titled Choice of Biologic Immunotherapy for Psoriasis or Psoriatic Arthritis and its Association with the Risk of Major Adverse Cardiac Events. Using data from the TriNetX database, which is a large federated health research network that contains de-identified information from multiple healthcare organizations across the United States, the authors identified more than 32,000 patients with either psoriasis or psoriatic arthritis who were new Biologic DMARD users. The most common Biologic DMARD was a TNF inhibitor in 62.9%, followed by IL-17 inhibitor, 15.4%, IL-23 inhibitor, 10.7%, and an IL-12/23 inhibitor in 10.7%. In a weighted multi-nominal Cox proportional hazards regression analysis, the adjusted risk of a major cardiac event, or MACE, was similar for IL-1A inhibitors, IL-23 inhibitors, and IL-12/23 inhibitors as compared to patients treated with a TNF inhibitor. Subset analysis supported the primary analysis. The use of this large database gives the best evidence to date that the choice of biologic DMARD selection in this population should not be guided by the patient's cardiovascular risk profile. In accompanying editorial titled Interdependent Cardiometabolic and Psoriatic Disease, an intriguing process that calls for more integrated interventions, Dr. Patrick Desson, Mopoti Saboka, and Ahmed Solomon from the University of Witwatersrand Medical School, Johannesburg, South Africa, review the mechanism of how inflammation can lead to cardiovascular disease in patients with inflammatory arthritis, and in particular in patients with psoriatic disease. They outline why rheumatologists should perform personalized evaluation and management of the cardiometabolic risk factors and its determining lifestyle factors, including weight control and enhanced physical activity. If the practicing rheumatologist wishes to improve their patient's cardiovascular health. The fourth paper to highlight is titled The Renal Activity Index for Lupus, Validation for Prediction of Kidney Inflammation in Adult Patients with Lupus Nephritis. In this paper, O'Connor and co-authors from the University of Cincinnati, USA, examined serial urine samples from a total of 240 patients who were enrolled in the Allure study to determine if the RAIL panel of 6 urinary biomarkers could predict the course of lupus nephritis. At week 12, 198 samples were available. At week 24, 116, while only 48 samples were available at week 52. They found that at week 52, 37.5% of patients had a complete renal response and 31.3% had a partial renal response. At all time points, lower RAIL scores were associated with a complete renal response, while for a partial renal response, this was only true at week 52. When compared to the urinary protein to creatinine ratio, they found that the urine protein creatinine ratio differentiated a complete response from no response, and could differentiate patients with either a complete or partial response from patients with no response. The authors concluded that RAIL scores identified patients with active lupus nephritis and longitudinally predicted the course of adult lupus nephritis. I leave it to you to determine the utility of RAIL scores in adult patients with lupus nephritis. The fifth and last paper to highlight is titled Effectivity and Safety of Febuxostat in Reducing Serum Urate in Gout Patients with Chronic Kidney Disease, a prospective multicenter ultra registry study, and is by O and co-authors on behalf of the Urate Lowering Therapy in Gout or Ultra Registry, and they're from the Republic of Korea. In this paper, they had 112 patients from the registry who are available for the final analysis of the effect of febuxostat, of which 77 had normal renal function and 35 had stage 3 or greater chronic kidney disease. They found that the baseline serum acid levels did not differ between the two groups. After febuxostat therapy, serum urate levels were significantly lower in the CKD group as compared to the group with normal renal function at both 6 and 12 months. They also found that the proportion of patients achieving a serum urate level of less than 6 milligrams per deciliter at 6 months was higher in the CKD group than in the group with normal renal function. In addition, the mean febuxostat dose tended to be lower in the CKD group. They found mild changes in mean AST and ALT levels, but were only clinically relevant in a very small proportion of patients, and there was no differences between the two groups regarding liver function tests. The authors suggested that the individualized febuxostat dosing strategy should be based on a serum urate level response to febuxostat treatment rather than renal function alone. Now I'll briefly review the other papers from this month's edition of the Journal of Rheumatology. Carrizio, Abarza, and co-authors in a paper titled Atlantoaxial Subluxation in Patients with Psoriatic Arthritis found that atlantoaxial subluxation was uncommon in their cohort of patients with psoriatic arthritis, with an incidence of 1.16 per 1,000 person years, but was associated with radiographic sacroiliitis and radiographic damage in the peripheral joints. Ali and co-authors in their paper titled A Global Survey of Quinacrine Use in Systemic and Cutaneous Lupus Erythematosus found that the majority of physicians prescribe quinacrine in combination with other antimalarial agents. And then, however, an important barrier to prescribing quinacrine was its lack of availability in many countries. Now moving on to papers focusing on pediatric rheumatology, Giaffino and co-authors in their paper titled Individual and Socio-Ecological Resilience in Childhood Onset Systemic Lupus Erythematosus, Association with Patient Characteristics and Psychosocial Patient Reported Outcome, showed that higher resilience was associated with fewer childhood adverse experience, better health literature, and better patient-reported mental health and executive function. There is a very insightful editorial which accompanies this by Dr. Kimberly DeQuarto from Stanford University, Stanford, USA, which is titled When You Walk Through a Storm, Stress Resilience and Coping in Rheumatology. The second pediatric paper is by Mastrolangelo and co-authors on behalf of the Sick Kids MSc Working Group, and is titled Screening Multisystem Inflammatory Syndrome in Children, Accuracy of the American College of Rheumatology Screening Algorithm showed that the American College of Rheumatology, or ACR, MSC, or Multisystem Inflammatory Syndrome in Children algorithm demonstrated high specificity, accuracy, and good sensitivity in identifying children with MSC at the onset of the disease. For those who are not familiar with multisystem inflammatory syndrome in children, it is a potentially fatal complication of COVID-19 infection characterized by hyperinflammation and fever with multi-organ dysfunction. Our Rheumatology Around the World article this month is by Garcia Salina and co-authors entitled Establishing Centers of Excellence of Axial Spondyloarthritis in Latin America, Consensus Recommendations from the Real Panlar Group. I think the title is self-explanatory. Our expert review article this month is a biostatistical article by Cook and co-authors titled The Use of Real-World Data for Studies of Dynamic Disease Processes. And they show how biases can arise from different types of analyses and how estimators from fitting such joint models can be used to gain both scientific insights and address common questions about treatment effects. In this day of big data, it is important to understand the potential pitfalls as well as the advantages of the analyses. Our Panorama 360 Degrees of Rheumatology this month is an interesting article. This is by Dr. Richard Panish and his grandchildren, which makes for interesting reading on how simple questions that children or adolescents can pose to you may lead to unexpected reflections on your medical career. We have one research letter this month, and it is by Mahajan and co-authors, entitled Rituximab versus mycophenolate mofetil for infection risk in systemic sclerosis. There are two case reports. The first is titled Calcium Pyrophosphate Crystals of the Brachial Plexus, a case report, and is by Tianov and co-authors. Well, the second is by Tyson and co-authors, as entitled Spondylodiscitis caused by Trophomia whipplei, report of two cases. There are two images in rheumatology this month. The first is by Hatano and co-authors and is titled Cotton Wool Appearance of Muscular Polyarteritis Nodosa on Contrast Magnetic Imaging, which shows the characteristic MR imaging of the lower limbs of a 9-year-old girl with polyarteritis nodosa involving skeletal muscle. The second is by Cato and co-authors titled Central Nervous System Vasculopathy in Systemic Sclerosis Resolved by Vasodilator Therapy, shows MRI images of reversible lesions in a 63-year-old female who, with a history of diffuse cutaneous systemic sclerosis, and subsequently was diagnosed with an ischemic stroke. I want to thank you for listening to this podcast and encourage you to read the complete articles in the March 2026 edition of the Journal of Rheumatology, either in the print or online editions. The latter is available at www.jroom.org. And again, please watch the interview of the highlighted article, not only this month, but previous month's interviews if you have missed them. They are available at our website and on our YouTube channels. As per my introduction, I have slightly altered the format of my summary for this edition of Editor's Summaries. I would appreciate feedback on which of the two formats you prefer. They are, one, what I've done in the past, which is summarize all the articles briefly, or today's format, where it went into more depth of 5 highlighted articles, which I felt were of particular importance, while giving a 1 to 2 sentence summary of all the other articles. Please send your thoughts on the future format of my podcast, or in fact, any comments or questions of any of the articles, the March edition of the Journal of Rheumatology. These can be sent directly to me at esilverman@jroom.com or to manuscripts at jroom.com. And please join me next month for the April 2026 edition of Editor's Summaries. Thank you for listening.